A 68-year-old retired teacher named Margaret walked into my office last spring. She'd been taking her blood pressure medication exactly as prescribed for 12 years. Never missed a dose. Checked her numbers religiously every morning. Her cholesterol numbers looked perfect on paper. Her cardiologist told her at her last checkup that she was doing everything right. She was the model patient. She followed every instruction. 3 weeks after her doctor added a second medication to protect her kidneys, Margaret collapsed in her kitchen while making breakfast for her grandchildren. Her husband found her on the floor, conscious but unable to stand, unable to explain what was happening. The paramedics arrived within 8 minutes. Her blood pressure was critically low. Her heart rhythm was erratic. What happened to her wasn't a heart attack. It wasn't a stroke. It was something far more preventable. And it happens to thousands of seniors every single month because two medications that seem perfectly safe on their own, medications that doctors prescribe together routinely, become quietly dangerous when they're combined inside an aging body. What I'm going to tell you today could be the most important 20 minutes you spend this week. My name is Dr. Richard Chen. I'm a cardiothoracic surgeon with 28 years in the operating room. I've opened over 2,000 chests in my career. I've held beating hearts in my hands, and I've spent nearly 3 decades watching the same preventable patterns repeat. Patients who did everything their doctors told them to do. Patients who never missed a dose. Patients who ended up in crisis not because they were careless, but because nobody took the time to explain what happens when certain medications interact inside an aging body. The pharmaceutical combinations I'm about to walk you through are prescribed together every single day, and most of the time they work exactly as intended. But after 60, your body processes medications differently. Your kidneys slow down, your liver becomes less efficient, and the safety margins that protected you at 50 start to disappear. Today, I'm going to tell you what nobody took the time to explain to Margaret. Here's what changes after 60 that makes medication combinations more dangerous than they used to be. Think of your body like an old car that's been running perfectly for decades. The engine still works. The transmission still shifts. Everything appears fine on the surface, but the tolerances have changed in ways you cannot see. A brand new car can handle a little too much oil, a slightly dirty filter, a few extra miles between tune-ups. The systems compensate. The margins are wide. An older car with 200,000 miles on it doesn't have that margin anymore. The same minor oversight that a new car would shrug off can cause serious damage in an older vehicle. Small errors compound. Ezekada obom nan sad. Tolerances narrow. In sam. Your body after 60 operates the same way. Your kidneys filter medications out of your bloodstream, processing them, breaking them down, eliminating what your body doesn't need. But by age 70, your kidney function has typically declined by 30 to 40% compared to what it was at 30. That's not kidney disease. That's normal aging. And it means medications stay in your system longer. They build up more. The half-life of drugs extends. And when you're taking two medications that both affect the same system, that buildup can cross from therapeutic into toxic without anyone realizing it's happening until you're in crisis. More than 70% of adults over 65 take at least 2 prescription medications daily. And the most common dangerous combination involves drugs that millions of seniors are taking right this moment. Now, the first combination I need you to understand involves 2 medications that protect your heart and kidneys in different ways, but together they create a perfect storm inside your body. ACE inhibitors. Anafendi Isaka. Millions of people take them. Lisinopril, enalapril, ramipril. These drugs lower your blood pressure by relaxing your blood vessels, making it easier for your heart to pump. They're incredibly effective. They save lives every single day, and they're often prescribed alongside diuretics, water pills like hydrochlorothiazide or furosemide. On paper, this combination makes perfect sense. The ACE inhibitor relaxes your vessels. The diuretic removes removes excess fluid, reducing the volume of blood your heart has to pump. Your blood pressure drops. Your heart works less hard. Your risk of heart attack and stroke goes down. But here's what nobody tells you. Both of these medications affect your potassium levels, and they affect them in opposite directions. The diuretic pulls potassium out of your body through your urine. Every time you urinate, you're losing potassium. The ACE inhibitor keeps potassium in. It blocks the hormone that normally helps your kidneys excrete potassium. When you're younger, your kidneys compensate. They balance the equation automatically. Your body adjusts. But after 60, especially after 70, that compensation system becomes unreliable. Your potassium levels can swing dangerously high or dangerously low, and you won't feel it happening until it's too late. High potassium hyperkalemia doesn't announce itself with chest pain or shortness of breath. It causes sudden heart rhythm disturbances, dangerous arrhythmias that can stop your heart in seconds. I had a patient, 72 years old, who'd been on this combination for 5 years without a problem. Then one morning he stood up from his breakfast table and his heart stopped. His wife started CPR. Paramedics shocked him 3 times. He survived, but the only warning sign he had was mild fatigue for 2 days before the collapse. Nothing dramatic. Nothing that screamed emergency. The question I want you to ask yourself right now is this: when was the last time your doctor checked your potassium level? Not at your annual physical 2 years ago, in the last 60 days. If you're on both an ACE inhibitor and a diuretic, your potassium should be monitored every 3 to 6 months. Write that down. That's not optional. That's the difference between safe and dangerous. The fix here is simple. If you're on this combination, call your doctor's office tomorrow morning. Ask them when your last potassium level was checked. If it's been more than 6 months, request a blood test. And if your doctor doesn't think it's necessary, find a doctor who does. Starting tonight, let me ask you something before we go further. Do you take a blood thinner? Warfarin, also called Coumadin, is one of the most prescribed medications in the world for people over 60. It prevents strokes. It prevents blood clots. It saves thousands of lives every year. But when you combine warfarin with certain antibiotics, the interaction can turn your blood dangerously thin in a matter of days. Here's the mechanism. Warfarin works by blocking vitamin K, which your body uses to make clotting factors. Your dose is carefully calibrated so that your blood is thin enough to prevent clots, but not so thin that you bleed uncontrollably. That calibration is fragile, and it depends on your gut bacteria producing a steady, predictable amount of vitamin K every single day. Antibiotics kill bacteria. That's their job. But they don't just kill the infection you're trying to treat. They also kill the beneficial bacteria in your intestines that produce vitamin K. When those bacteria die, your vitamin K levels drop. Your warfarin suddenly becomes more potent, and your INR, the measure of how thin your blood is, shoots up into the danger zone. After 60, this risk is amplified because your liver metabolizes warfarin more slowly. The drug stays in your system longer, and when an antibiotic like ciprofloxacin or trimethoprim sulfamethoxazole gets added to the mix, the combination can push your INR from a safe 2.5 to a dangerous 6 or 7 in 72 hours. I've seen patients develop spontaneous bleeding, brain hemorrhages, internal bleeding that required emergency transfusions. And the terrifying part is that most of these patients had no idea the antibiotic their dentist prescribed for a tooth infection could interact with the blood thinner their cardiologist prescribed for atrial fibrillation. The two doctors never spoke to each other. The pharmacy flagged the interaction, but the patient didn't understand what the warning meant. And 3 days later, they were in the emergency room. Stay with me. 2 more combinations after this one. And the next one, number 3, is the one that even I had a significant blind spot about for the first 15 years of my career. This next one surprises people every time. time. NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, medications you can buy over the counter without a prescription, without even talking to a pharmacist. Millions of seniors take them every day for arthritis, for joint pain, for headaches, for muscle aches, and most people don't think of them as dangerous because they're available without a prescription. They're sitting on the shelf right next to the vitamins. But when you combine an NSAID with a blood pressure medication, especially an ACE inhibitor or an ARB, the NSAID quietly sabotages everything the blood pressure medication is trying to do. Here's what's happening inside your body at the cellular level. ACE inhibitors and ARBs lower your blood pressure by relaxing your blood vessels. They work on the hormone systems that control vascular tension. NSAIDs raise your blood pressure by constricting those same vessels. They block the production of prostaglandins, chemicals your body uses to keep blood vessels relaxed and kidneys functioning properly. They also make your kidneys retain salt and water, which increases your blood volume and drives your pressure even higher. The result is that your blood pressure medication stops working as well as it should. Your pressure creeps up 5 points, then 10 points. Your doctor sees the higher numbers at your next appointment and increases your dose. But you're still taking the NSAID every day for your knee pain, so the higher dose doesn't bring your numbers down as much as expected. Your doctor adds a second blood pressure medication. You're now on 2 drugs instead of 1, and the cycle continues. For years, I told patients with high blood pressure to avoid NSAIDs, but I didn't explain why in a way that felt urgent. I treated it like a suggestion, not a warning. I'd say, try to limit ibuprofen if you can, and then I'd move on to the next topic. And then I started tracking. I started counting how many of my patients who ended up needing more aggressive interventions, more medications, sometimes even surgery for heart failure, had been taking ibuprofen regularly for months or years without realizing it was undermining their entire treatment plan. The number was staggering, more than 60%. This is where the damage is silent. You don't feel your blood pressure going up by 10 points. You don't feel your kidneys being stressed. You don't feel the extra fluid building up. But over months and years, that silent damage accumulates. Kidney disease, heart failure, strokes, all preventable. Do you take ibuprofen regularly? Even just twice a week for your back, for your knees, for headaches? If you're also on a blood pressure medication, you need to stop, not cut back. Stop. And if you need pain relief, talk to your doctor about alternatives. Acetaminophen is safer for your blood pressure and your kidneys. Topical creams work for joint pain without affecting your cardiovascular system at all. The question to ask your doctor, write this down. What is the safest pain reliever I can use that won't interfere with my blood pressure treatment? That conversation could save your life. Here's where it gets complicated. Statins, cholesterol-lowering drugs like atorvastatin, simvastatin, rosuvastatin. Tens of millions of people take them. They prevent heart attacks. They prevent strokes. They're one of the most important medications in modern cardiology. But when you combine a statin with certain other drugs, the statin's concentration in your bloodstream can skyrocket, and that leads to a condition called rhabdomyolysis, muscle breakdown. Your muscle tissue starts to dissolve. The breakdown products flood into your bloodstream. Your kidneys try to filter them out, but the load is too high. Your kidneys fail. This is not theoretical. It happens. And it happens most often when statins are combined with medications that interfere with the enzyme system your liver uses to break down the statin. The medications that cause this problem include certain antibiotics, antifungals, and even grapefruit juice in large amounts. But the most common culprit in seniors is a class of drugs called fibrates, which are also used to lower cholesterol, specifically triglycerides. Gemfibrozil is the biggest offender. When gemfibrozil is combined with a statin, the risk of rhabdomyolysis increases more than tenfold. I had a patient in his mid-70s who'd been on simvastatin for years. His triglycerides were still high, so his primary care doctor added gemfibrozil. Within 6 weeks, he was in my office complaining of severe muscle pain and dark urine. His kidneys were failing. We stopped both medications immediately, started IV fluids, and monitored him in the hospital for 4 days. He recovered, but he came within hours of needing dialysis, and the entire crisis was caused by a drug combination that should never have been prescribed in the first place. If you're on a statin and your doctor wants to add a medication for triglycerides, ask specifically, is this gemfibrozil? If the answer is yes, ask about fenofibrate instead. Fenofibrate has a much lower interaction risk with statins. Or ask about fish oil. High-dose omega-3 supplements can lower triglycerides significantly without the drug interaction risk. The fix is knowing the question to ask before you fill the prescription. I need you to hear this clearly because this is where the most preventable damage happens. The fifth combination involves drugs that seniors are prescribed all the time, often by different doctors who don't communicate with each other. Medications that affect serotonin. This includes antidepressants like SSRIs, sertraline, escitalopram, fluoxetine. It also includes certain pain medications, tramadol being the most common, and it includes migraine medications called triptans. When 2 or more of these drugs are combined, they can cause a condition called serotonin syndrome, inadvertent and fee. Too much serotonin in your brain and body. It starts with agitation, confusion, rapid heart rate, high blood pressure. It can progress to seizures, dangerously high body temperature, and in severe cases, death. After 60, the risk is higher because your body clears serotonin more slowly, and because seniors are more likely to be taking multiple medications prescribed by multiple specialists who may not know what else you're taking. I treated a woman in her late 60s who was on an SSRI for depression. Her primary care doctor had prescribed it years earlier. Then she developed severe back pain. A pain specialist prescribed tramadol. She took both medications for 3 days. On day 4, her daughter found her confused, sweating, and shaking uncontrollably. She was in serotonin syndrome. We stopped both medications, gave her supportive care, and she recovered. But it was close. And it was completely preventable. Here's what nobody tells you. When you see a new doctor, a specialist, an urgent care provider, anyone who might prescribe you a medication, you need to bring a complete list of everything you're currently taking. Not just prescription medications. Supplements too. St. John's wort, a common herbal supplement for mood, also affects serotonin. If a new medication is being added, ask, does this interact with anything I'm already taking? And if the doctor says no without looking at your list, ask them to look again. Your safety depends on you being the connection point between all your different providers. That's not how it should be, but that's how it is. I want to be honest with you for a moment, not as a content creator. As a surgeon, I have stood at an operating table at 3 in the morning holding a heart that had been damaged not by genetics, not by bad luck, but by a preventable medication interaction that went unnoticed for months. I have spoken to families in waiting rooms at dawn, families who had no idea anything was wrong when they said goodnight 8 hours earlier. In case after case, the contributing factors were not mysterious. They were ordinary prescriptions, combinations that millions of people take every day, an ACE inhibitor and a diuretic without regular potassium monitoring, warfarin and an antibiotic without an INR check, a statin and a fibrate prescribed by 2 different doctors who never compared notes. These are not exotic risk factors. They are the background noise of millions of ordinary medicine cabinets. And that background noise, accumulated day after day, month after month, destroys hearts, damages kidneys, and ends lives. I want to tell you about a patient. I'll call her Linda, 71, retired nurse, sharp as a tack. She came to me after experiencing severe dizziness and fainting episodes that her primary care doctor couldn't explain. When I reviewed her medication list, I found she was on an ACE inhibitor, a diuretic, and an NSAID she'd been taking over the counter for knee pain. Her potassium was dangerously high. Her kidney function had declined significantly over 6 months. Nobody had connected the dots. We stopped the NSAID immediately. We adjusted her blood pressure medications. We monitored her potassium weekly for a month, then monthly after that. 6 months later, she had gone from taking 5 medications to 3. Her kidney function stabilized. Her dizziness disappeared. Her energy came back. The first thing she said to me at her follow-up was, "Why didn't anyone tell me this sooner?" That question has stayed with me. It's a big part of why I make videos like this one. It is never too late. So here's what we've covered today. First, ACE inhibitors combined with diuretics can cause dangerous potassium imbalances if not monitored regularly. Get your potassium checked every 3 to 6 months. Second, warfarin combined with certain antibiotics can make your blood dangerously thin within days. If you're prescribed an antibiotic while on a blood thinner, ask your doctor if your INR needs to be checked sooner than usual. Third, NSAIDs like ibuprofen interfere with blood pressure medications and can damage your kidneys over time. Stop taking them if you're on blood pressure treatment and ask your doctor for safer alternatives. Fourth, statins combined with fibrates, especially gemfibrozil, can cause life-threatening muscle breakdown. If you need both, make sure it's fenofibrate, not gemfibrozil. Fifth, medications that affect serotonin, including certain antidepressants and pain medications, can cause serotonin syndrome when combined. Always tell every doctor exactly what you're taking before they add anything new. Which of these combinations do you recognize in your own medication routine? Tell me in the comments. I read every single one. There is someone in your life, a spouse, a sibling, a friend, who needs exactly this information. Send it to them. That one share might be the most important thing you do today. Every week, I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. If you want more of that, subscribe. One last thing, and this is important. Everything I've shared today is based on published research and my clinical experience as a cardiothoracic surgeon, but your situation is unique. Your history is individual. Before changing anything, any medication, any supplement, any routine, please talk to your own physician first. That conversation is not a formality. It is the whole point. Better information, better conversations, better outcomes. That's the chain that matters. Your heart has been working for you every single minute of every single day for 60, 70, 80 years without ever asking for anything in return. Give it this. Take care of your heart.